I would like to thank the organizing committee for the invitation. I'm very honored and pleased to participate in this meeting. And the theme of my speech is SGLT2 inhibitors and acute kidney injury. As we all know, SGLT2 inhibitors belong to a novel class of glucose-lowering agent with additional benefits on weight, serum uric acid level, and blood pressure control. And in addition, it exerts a protective role on cardiovascular and renal function. But there have been cases with AKI that have been reported, and that created a little bit of concern in the nephrology community. So several studies have been made in an attempt to see if there is a relationship between their use and AKI, and if other factors like age or proteinuria participate in the AKI. So let's see how these agents work. At first place, they inhibit the absorption of sodium and glucose in S1 segment of the proximal tubule, and that makes the concentration of glucose and sodium chloride to be elevated in the lumen of the tubules, which makes the amount increased in the thick ascending limb, which increase the expenditure of energy in the medulla. And in addition, reaching to macula densa, this increased concentration is sensitized and activates tubuloglomerular feedback, leading to constriction of the afferent arteriole and leading to its part to a fall in the GFR. In addition, glucose uptake is increased in S3 segments and leads to fructose production, and in its turn to high levels of uric acid, oxidative stress, and tubular injury due to intracellular accumulation of sorbitol and fructose. They serve and they can be regarded as diuretics since they provoke natriuresis and osmotic diuresis. So the ischemia that is seen in medulla in normal condition is exacerbated due to the use of these agents. And in diabetic rats, they saw that the oxygen tension in the renal cortex was increased, while in the medulla was significantly decreased. And the part of the tubule that is damaged is the distal one, sparing the cortical. And that was evidenced by the high amounts of serum and urine and gall. This hypoxia leads to the stimulation of erythropoiesis. Hypoxia stabilizes the hypoxia-inducible factor 2A. So we have high levels of hematocrit and hemoglobin, and this fact is not due to hemoconcentration due to diuresis, but to increased hemopoiesis, and that was evidenced by the high levels of reticulocytes. Another mechanism of that leads to AKI is uricosuria. Their use is associated with decreased level of uric acid in the serum and increased in urine, and that makes possible AKI due to crystalline dependent or independent pathways. Unfortunately, we do not have data from kidney biopsies, only from case reports in the literature. Here is a case of acute tubular necrosis in a patient who received dapagliflozin, and it's characteristic the intraluminal necrotic debris, the infiltration of inflammatory cells in the interstitium, but we can also see that epithelial cells are flattened and some of them are detached from the tubular basement membrane. Tubulointerstitial nephritis was observed in patient after the use of SGLT2. And here is again the infiltration of inflammatory cells, primarily surrounding the tubules and leaving the glomerulus, the infiltration around the tubulus is minimal. Here is a case of an acute interstitial nephritis, and there have been described cases of osmotic vacuolization of proximal tubular epithelial cells with very characteristic images in the electronic microscope. Osmotic nephrosis have been described as well. Here are the tubules that present osmotic tubulopathy. And in immunofluorescence, we see the increased expression of aldose reductase and fructokinase. So after an episode of AKI, mechanism of repair are taken in charge. If this repair is maladaptive, then fibrosis appears. And the extension of fibrosis seems to be extended if another insult occurs. In mice, there have been proved that luceoglyphosine attenuates fibrosis and promotes angiogenesis. So the area of fibrosis is extremely limited. Contrast media is a cause of AKI, as we all know. So the question is, if our patients are on treatment with these inhibitors, would they have a deterioration of kidney function? As a pilot study, but with a small number of participants, showed that before intervention and 24 hours afterwards, there was a difference between the values of creatinine in a statistically significant way. But this significance was lost at 48 hours. 6 hours after the intervention and GAL was measured, the values were higher in the SGLT2 inhibitors group compared to placebo, but between them there was no statistical significance. All randomized controlled trials report an initial dip in eGFR, between 3 to 5 ml per minute. And this should not be the case for stopping them, because it's an inherent characteristic of these drugs. In addition, it seems to retard the progression of CKD, and that's a great benefit for our patients. Trials looking for a cardiovascular outcome and renal outcome in diabetic and non-diabetic patients have shown positive results. But the question is, what makes SGLT2 protect the kidney? So they have created some experimental models of AKI, such as cisplatin-induced acute kidney injury, where ganagliflozin showed that it inhibits apoptosis, and the marker of apoptosis are minimally expressed, while it induces autophagy. So the cell viability increased in a statistical significant way, and the tubular injury score was decreased. Epagliflozin in diabetic rats with acute kidney injury after myocardial infarctions attenuated the enlargement of the glomerular area, reduced oxidative stress, but it didn't have the same results on inflammation as it was expressed by inflammatory markers. Serum clotho and urine clotho are increased as well, and this increase seems to be maintained even when the cells are in a milieu of inflammation or proteinuria. They seem that they limit the podocyte damage, preserving their structure and preserving their number as well. So their use might be of benefit in glomerulopathies, either primary or secondary. A very recently published report showed that the administration of SGLT2 inhibitors are safe if they are co-administered with immunosuppressive treatment. And in addition, it has shown that GFR is ameliorating while proteinuria is diminishing. What about kidney transplant recipients? There are no data in the literature with trials with a number of patients. There are only a few with very few participants. But in diabetic kidney transplant recipients, the use of SGLT2 inhibitors showed a benefit in patients and graft survival without major or frequent adverse events. The use of dapagliflozin in patients who had cardiometabolic risk factors and were hospitalized with COVID-19 present acute kidney injury, but their number was smaller in the dapagliflozin group compared to placebo. So it's obvious that their use has a positive effect on lowering glucose in the blood and have beneficial effect in several other aspects. And it seems that has a protective role for the kidney function. But when there are risk factors like nephrotoxic agents or hypotension or hypovolemia, should this agent be withheld in the presence of high-risk clinical situation? That's a question that remains to be answered. Thank you.